Good evening. I am Dr. Priyadharshini. Today I am going to take INI-CET revision class in dermatology. So in dermatology, we are going to see very important topic and a very important topic from this topic, which is basement membrane structure. Today we are going to see basement membrane structure. This can be asked in many MCQs as a separate direct question, or in immunobullous disorders. To solve the MCQs, you need to know about the basic structure of this basement membrane to answer the questions. So in a basement membrane, what is a basement membrane is, in the structure of skin, there is epidermis, there is dermis. In between the epidermis and the dermis, what we have is a basement membrane. And in epidermis, it has individual keratinocytes lying together, held by the junctional protein called as desmosomes. So this is the basic structure of skin, and this desmosome has some protein called as desmoglein and other proteins also are included in this desmosome called as desmoplakin, envoplakin, periplakin, plectin, and in between these two base keratinocytes, these desmosomes are present, and it has desmoglein 1 and 3, and this is a basal keratinocyte layer, and in the between the basal keratinocyte layer and the basement membrane, what we have a protein called as hemidesmosome. This hemidesmosome has two proteins called as BPAG1 or BP230 or BPAG2 or BP190. So these two are the components of hemidesmosomes. So this is a hemidesmosome. What you see here, this is the basal keratinocyte, and this is a hemidesmosome which is present in between the basal keratinocyte and the basement membrane. So hemidesmosome has BPAG1, which is well inside the basal keratinocyte, and BPAG2, it's a J-shaped structure. This is BPAG2. Then what we have here is the other structures included in basement membrane. Basement membrane has three components called as lamina lucida, lamina densa, and sublamina densa region. So in lamina lucida, what we have here is integrin, alpha 6 and beta 4, and plectin. And BPAG2 is also present in lamina lucida. Three components lamina lucida has is BPAG2, integrin alpha 6, and integrin beta 4, and plectin is also present in lamina lucida. Next is lamina densa, which is the second part of basement membrane, which has two components. Laminin 332 and type 4 collagen. What you should know here is type 4 collagen, although it is present in the basement membrane, this sublamina densa region has other types of collagen. So type 4 collagen is specifically present in the lamina densa of the basement membrane. This you should know. And sublamina densa region is also a part of basement membrane, which connects the basement membrane to the dermis. So it has three components: elastin, type 7 collagen, and type 1 and 3 collagen. So why you should know all these proteins components is that it is involved in all the immunobullous disorders, each disorders, and we'll see it one by one later. So this is the structure of basement membrane, structure of basal keratinocytes, and the proteins involved in this. So the possible MCQs they can ask from this is lamina lucida, the components BPAG2, integrin alpha 6 and beta 4, and plectin. And lamina densa has laminin 332 and type 4 collagen, and sublamina densa region has type 7 collagen and type 1 and 3 collagen. So this you should remember. Next is the components. All these components are involved in causation of certain diseases. So we'll see it one by one. So what I told here is desmosomes. These proteins, these are called as calcium mediated adherence protein, which is present in between two keratinocytes. So these are called as cadherin proteins, and it has desmoglein 1 and 3 as a primary component. So this desmoglein 1, antibodies to this desmoglein 1 is involved in causing pemphigus foliaceus. So in pemphigus foliaceus, this desmoglein 1 is affected, and desmoglein 3, antibodies to desmoglein 3 causes oral lesions, only mucous membrane lesions of pemphigus vulgaris, and antibodies to both desmoglein 1 and 3 is associated with both oral and cutaneous lesions of pemphigus vulgaris. So this you should know. Next is other components of desmosomes, as I told earlier. Here you can see invoplecin, periplecin, desmoplecin, plectin, desmocoin. All these 5 proteins are the other components which are present in the desmosomal junction. So this invoplecin, periplecin, desmoplecin and plectin will be involved in paraneoplastic pemphigus. So antibodies to all these proteins will be present. In case of paraneoplastic pemphigus, which is due to any malignancy, most commonly due to non-Hodgkin's lymphoma, and antibodies to desmocollin 1 will be there in IgA pemphigus. This is also a variant of pemphigus vulgaris only. So all these are defect antibodies to the desmosomal proteins. So next is antibodies to the basement membrane proteins causes certain diseases. So antibodies to BPAG1 and 2, which is also called as BPAG1 is also called as BP230 and BPAG2 is also called as BP180. It is associated with causation of bullous pemphigoid, and this BPAG2 is also called as, the other name of BPAG2 is called as type 17 collagen. So this type 17 collagen not only causes bullous pemphigoid, and apart from that it is also associated with the causation of other certain conditions which we will see now. BPAG2 is associated with 4 conditions mainly bullous pemphigoid, and other 3 conditions associated with BPAG2, antibodies to BPAG2 will be present in gestational pemphigoid, which is nothing but the clinical variant of bullous pemphigoid which occurs in pregnancy, and in linear IgA disease you have antibodies against BPAG2. Other antigens involved in this linear IgA disease is LAD1 antigen, and cicatricial pemphigoid also has antibodies to BPAG2. So the 4 conditions which involves antibodies against BPAG2 is bullous pemphigoid, gestational pemphigoid, linear IgA disease and cicatricial pemphigoid. So this BPAG1 and 2 and the disease association you should know it clearly. They might ask in exams. And this laminin is a component of lamina densa of basement membrane, as we saw earlier. So this laminin and alpha-6 beta-4 integrins is involved in causation of cicatricial pemphigoid or mucous membrane pemphigoid. So these are all the proteins which involved in causing some epidermal bullous disorders. So all these proteins, all these components and the diseases you should know thoroughly to answer any of these questions asked from this topic. Next, what you're going to see is how to diagnose each of the bullous disorder clinically. So if they in exam they can give you a clinical scenario, which is nowadays very common in both INI-CET and NEET exam also. So they can give you a clinical scenario and ask you the diagnosis or next step of investigation or something like that. So in such a case, usually in immunobullous disorder, it's a very important topic. 1 or 2 MCQs always come in all exams, especially in INI-CET. It's the favorite topic of INI-CET question setters. So they might give you a clinical scenario and ask you what is the diagnosis or any questions related to that. So as a first step, you have to decode the clinical scenario and arrive at the diagnosis. So here are the key points which they may give in their MCQs, and you can arrive at the diagnosis by using this key points or the spotting points or spotters. So first one is if they give history, in the question, if they give a patient presenting with flaccid bullae or Nikolsky sign positive or bulla spread sign positive, this mainly indicates diagnosis of pemphigus vulgaris. Not only pemphigus vulgaris and also its variants, which includes pemphigus foliaceus, pemphigus vegetans, and pemphigus erythematosus, all those things. So flaccid bullae will occur in intraepidermal bullous disorder, mainly pemphigus vulgaris and its variant. This you should remember. And in such condition, Nikolsky sign will be positive and bulla spread sign will also be positive. So this is the first clinical pointer, and the diagnosis is this. Next clinical pointer, next in other question, what they might give us, tense bulla. Tense bulla not rupturing very commonly, and Nikolsky sign is negative, bulla spread sign is negative. So this points towards a subepidermal bullous disorder. So the most common subepidermal bullous disorder is bullous pemphigoid, which occurs in older age groups. Apart from that, other subepidermal bullous disorder can also have similar presentation. Other subepidermal bullous disorder includes pemphigus gestationis, which I told earlier, linear IgA disease, all mucous membrane pemphigoid, all these are dermatitis herpetiformis, all these are other subepidermal bullous disorders. All other diseases will have tense bullae only. You have to just give other conditions. Apart from this bullous pemphigoid, other conditions will have other pointers, so which I will explain you later. So you can diagnose it clearly. Apart from these pointers, other pointers which can point towards bullous pemphigoid is complaint of itching. Complaint of itching will be very severe in case of bullous pemphigoid, and its association. It is mainly associated with old age drugs. Drugs associated with bullous pemphigoid is loop diuretics, furosemide, spironolactone, beta blockers, calcium channel blockers, penicillin group of drugs. All these drugs are involved, and the disorders which are associated with this bullous pemphigoid is neuropsychiatric disorders, and all the neurological disorders will be associated with this bullous pemphigoid. So all these are pointers towards this. And apart from this flaccid bullae, Nikolsky sign, and bulla spread sign, cornflake-like crest will be seen in case of pemphigus foliaceus. So this is a key point towards pemphigus foliaceus. In pemphigus foliaceus, the split is at the level of subcorneal level. So you won't have no obvious bullae, but crusting will be there. So this cornflake crest will be seen in case of pemphigus foliaceus. And malar rash and bullae, so something related with SLE or some SLE variant of pemphigus. So pemphigus erythematosus can occur with this presentation. Vegetating plaques, as the name indicates, you can easily diagnose it as pemphigus vegetans, which is associated with vegetating plaques and pustules. Apart from this, patient may also have one more important pointer called as cerebriform tongue, which can also occur in pemphigus vegetans. And polymorphous skin lesions of various morphologies like vesicles, bullae, hemorrhagic bullae, ulcers, many things can present in this condition called as paraneoplastic pemphigus, which is associated with malignancy, as I told earlier. And recalcitrant mucositis is also a very, very significant finding in case of paraneoplastic pemphigus. So if they give any such key pointers in the questions, so you can diagnose this with this key pointer. And next one is history of tense bullae only the patient is having, and history of lesion in pregnancy. And if the lesions are mainly around umbilicus, so all these pointers suggest towards pemphigus gestationis, which is nothing but the clinical variant of bullous pemphigoid, which occurs in pregnancy, mainly in the later part of pregnancy, second and third trimester. And lesions, this tense bullae, if it is associated with this appearance, string of pearls or cluster of jewels appearance, then it points towards linear IgA disease. And if the linear IgA disease occurs in the childhood, it is called as chronic bullous disorder of childhood. So mainly the string of pearl, the classical string of pearl or cluster of jewel appearance mainly occurs in chronic bullous disorder of childhood. And if the patient is having lesion only on all the mucosal area, it is very easy to diagnose. It's mucous membrane pemphigoid, and it will be associated with scarring. And next clinical scenarios, itchy papules. Itchy papules and vesicles on the extensor surface with gluten sensitivity is there. In such case, the gluten sensitivity points towards something related to gluten-related intolerance or something like that. This occurs only in this condition called as dermatitis herpetiformis. So this associated with itchy papules and vesicles. So these are all the clinical scenarios by which you can diagnose the condition and you can solve the MCQs. So this is very important and basic stuff you should know before knowing anything in immunobullous disorder, before knowing any direct immunofluorescence finding or any treatment or anything like that. In further class, we will discuss other important topics which will be asked in INI-CET. This is all for today. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.